We will now begin with our first session. To introduce the speakers is our moderator. He is the chairman of the Brain and Spine Center in Zamboanga City Medical Center and is the treasurer of the Philippine Academy of Vascular and Interventional Neurology. He is also the PRO of the Stroke Society of the Philippines and is the past president of the Stroke Society of the Philippines, Zamboanga Peninsula Chapter. Let us all welcome our moderator, Dr. Muqtader Calbi.
Good morning, esteemed colleagues, distinguished guests, and friends. Welcome to our first plenary session of the PAVIN First Biennial Conference and Grand Launch under the theme Stroke Pathways Reimagined, Advancing Precision, Progress, and Philippine Perspective. This session, the primary and secondary prevention, brings together leading experts whose work continues to redefine how we understand, prevent, and manage stroke in the Philippine context. Our first speaker is a highly respected figure in both neurology and psychiatry. He is a fellow and past president of the Philippine Neurological Association, a diplomat. He is a fellow and past president of the Philippine Neurological Association, a diplomat of the Philippine Board of Psychiatry, and a life fellow of the Philippine Psychiatric Association. So our first speaker has served as the past chairman of the Department of Neuroscience and Behavioral Medicine, formerly the Department of Neurology and Psychiatry at both the University of Santo Tomas Hospital and the Faculty of Medicine and Surgery. It is my honor to introduce Dr. Alejandro Baroque II, who will deliver his lecture entitled Genomic Signatures and Biomarkers for Stroke, Redefining Risk in the Philippine Population. Our second speaker is a distinguished vascular neurologist and an academic leader. He is a full professor at the Department of Neuroscience and Behavioral Medicine, College of Medicine, University of Santo Tomas, and currently serves as the president of the Philippine Society of Hypertension. He is also a fellow of the Philippine Neurological Association, a peer reviewer of the Journal of Medicine of UST, and has led national initiatives such as the May Measure Month, BP Awareness from 2019 to 2021. Please welcome Dr. Alejandro Bimbo Diaz, who will present his lecture, The Neuroimmune-Psychosocial Stress Axis and Cardio and Cerebrovascular Disease Mechanism and Therapeutic Implications. Our third speaker brings both international training and regional leadership to the field of stroke medicine. He completed his residency in adult neurology at the University of the Philippines, Philippine General Hospital, followed by a clinical and research fellowship in stroke at the National Neuroscience Institute, Singapore General Hospital. He is a clinical instructor at the Xavier University's Dr. Jose Rizal School of Medicine and College of Medicine at the University of Science and Technology at Southern Philippines. He also served as the chapter president of the Stroke Society of the Philippines, Northern Mindanao, and is a consultant at Madonna and Child Medical Center in Cagayan de Oro City. We are privileged to hear from Dr. Loreto Talabucon Jr., who will discuss redefining antithrombotic therapy from broad-spectrum agents to factor 11 precision inhibitors. As a reminder, throughout the lecture, a QR code will be flashed on the screen. We encourage all attendees to scan the code and send in your questions. These will be entertained during the open forum after all lectures have been delivered. And now, to begin our session, may I call on our first speaker, Dr. Alejandro Baroque II.
Magandang umaga po sa inyo lahat at ako po'y unang-una sa lahat po ay nagpupugay at nagpapasalamat sa inyong naitalagang presidente, Dr. Alan Belen, sampu ng kanyang mga opisyal at membro ng lupon ng PAVIN at kasama na po ang organizing committee, particularly referring to Mark Molina and and I plan to start my talk with lamentation. Since I started lecturing in a forum like this 35 years ago, I've been challenged with the most challenging topics that was assigned to me, including this particular morning. However, credit must be given, and when it is due, I will brush off that lamentation because kailangan ko pong bahagi sa tagumpay at maayos na pagpapasinayan ng lupon ng PAVIN itong umagang ito. At sa unang pagkakataon sa pagpupulong, nakikibahagi po ako at pasalamat at ako'y nabigyan ng pagkakataon makitalakay sa inyo. Let's go ahead with my topic, Genomic Signatures and Biomarkers for Stroke, Redefining Risk in the Philippine Population. This is just one topic lecture better than the next speaker, which you will see, the title. I think we missed out on the organizational meeting with the Scientific Programs Committee. At any rate, all right, what I wish to accomplish here is to find out the origins of this particular specialty, genomic principles, and find out how it will contribute to a better and more precise diagnostic acumen in approaching our stroke patients, probably with the precise method of classifying each of these particular stroke varieties, which is multivariate, as you will probably understand. And it was emphasized a while back, it is not an accident anymore. There's got to be a reason why one is having stroke. And how perhaps we will likewise improve on the therapeutic interventions with more precise medicine, so to speak, as will be emphasized by the next speakers later on, and how in the future it will be applicable to our Philippine setting, all right? Because genomic science is kind of new. We're all familiar with all of the statistics and epidemiologic data regarding strokes, and this is the newest one. The data is coming from the 2021, but this has been fact sheet to 2025 by the WHO. From 2019 up until 2009 up until the present, there has been a 70% increase in the number of new cases of strokes, and there is about 44% increase in the death of stroke patients, 7 million, and those who will survive together with the new addition, you have an 86% increase from that time up to the present, having about 94 million having strokes at this particular moment, increasing now the disability adjusted life years to about 32%, and you will see that the daily score is highest in the Asian country, Philippines, to be included. More important than this, the observation from 2009 up until the present, you have a steady rise of new onset, the younger individuals, younger population stroke, less than 70 years old, about 53% of our stroke patients. And you'll be surprised that less than 50 years old, you have at least about 16 to 20% of the stroke population. And of course, the modifiable risk factors, they are all there. All right, hypertension, diabetes, dyslipidemia, and everything else. And looking at the Philippine setting, this is still the second most common cause of mortality, second cause of disability, adding to the data that has been provided to us. And this is for the same reason that you begin to ask, well, why is that so? We have already, advanced so much in our understanding of the etiology, pathology related to stroke. All right, we have mapped it out adequately, and as a matter of fact, we have already introduced the most important and most potent of all of the interventions that will address and nip it in the bud, the obstruction itself. All right, so we have the interventions that were introduced, RTPA, thrombolysis, and thrombectomy. But as you will see, in thrombolytic therapy, it will only probably benefit 21% of the patients who have had the privilege of being administered with thrombolytic therapy. Not to mention the barrier, particularly in our part of the world. Siguro 5 out of 100 lamang ang pwedeng matrombolysis. And out of that, 21% lang ang magkakaroon ng acute recanalization. The same thing is true particularly with thrombectomy. All right, we all thought na, okay, nagbara yung ugat, ating sungkitin, wala, tapos na dapat ang problema. But that is not so. You have futile recanalization to more than half of the patients that would have benefited from thrombectomy, which is quite and more, probably much lesser than that of those who will benefit from thrombolytic therapy. Siguro isa-dalawa lamang out of 100 that will be eligible for thrombectomy. So, more or less, what we're looking at here, ba't kulang pa ata yung ating ginagawa? So, we look the other way around, or we have looked back to the other interventional strategies, and we're looking at neuroprotection or cerebroprotection for that matter, and that will prevent and retard infarct progression and more or less including reperfusion injury protection. So we're looking at neuroexcitatory antagonists, antioxidants, and anti-inflammatory, and those that will protect the blood-brain barrier. This is the newest article that we have reviewed, and the intervention strategies, and you can see here edaravone and some other items that will be important that have been introduced in the market today. And again, we look at the risk factors, modifying all of them prior to the onset of the stroke. But as I've told you a while back, there is at least about 16 to 20% of our patients who belong to the younger age group. And of course, there are unique risk factors, likewise, that we'll have to include and factor in the genetics. This is exactly where we started the looking at the possibility of the genomes, all right? It was the first reported completed human genome project was in 2003, and it included at least about 10 individuals. One individual represented 70% of all of the analysis, the haplotypes and the single nucleotide polymorphisms, and we have mapped, they have mapped at least about 3 billion DNAs sequences, which will and had been identified to provide at least about 25,000 only, coding for 25,000 proteins only. Whatever happened to the 99%, it is, again, that's the reason why you have the completed genome sequence came only after about 10 years with the improvement of the capabilities and technology. So dito pa lang nabuo, and what they found out, it is the repeat sequence that seems to be the problem with the genome project that was reported in 2003. So we have this field of specialty right now, the genomics, which will be the sum of all genetic materials in individuals, and providing us with all of the information that why the color of the eyes, etc. And if and whenever some of these sequence of DNA materials, we call the genes, will be interfered with, injured, or will have deletions, or whatever we call it, mutations, all right, you will have, and it will be a phenotypic pathology or disease for that matter. All right. So the most important gene that we'll have to focus right now is that which is responsible for, okay, I'm so sorry about that. Okay. Okay, for strokes, all right. What is the role of this genomic status insofar as stroke is concerned? It might serve as one of the biomarkers that we have been accustomed to. All right, we have a lot of biomarkers that we can look into. All right, and this is just a summary and looking at their contribution to the diagnosis, precise diagnosis of whether, and classification of strokes. The non-traditional, non-cholesterol had been associated with large artery atherosclerosis, particularly triglycerides and non-HDL. And more than this, we have also inflammatory markers, interleukin 6, and you have some hemodynamic markers, MR pro-NAP and pro-BNP, okay, and one of which will be the genetic abnormalities, which we have been seeing quite a while right now, and has been included in the promising biomarkers for stroke. All right. So, looking at the suggestion that ischemic stroke might be really be, well, it is really a genetic problem, and then they have analyzed how do we be able to have some association with some genetic abnormalities with the presentation of stroke. The first ever that I would like to emphasize here is chromosome 921, P21, and they have looked into the patients who have a myocardial infarction and looked at the mutation in the genes, particularly in the 9p21, chromosome 9p21, in between this important CDKN2A and CDKNB, all right, and the mutations of the gene sequence in between this will present with high risk for myocardial infarction. Likewise, the genes around, in and around proximity of 9p21.3 has been associated with the expression of diabetes and atherosclerosis, all of which are the same risk factors, not only for myocardial infarction, but likewise for strokes. And you will probably see the 1, 2, 3, 4, that those are the genes related to the red bar at the bottom, all right, which is the myocardial infarction. They share the same genetic risk locus in mutation of these particular areas. So they concluded genetic association for stroke is there, and it has been established, and association shares pathogenic mechanisms with heart disease and diabetes. All right, and this discovery was in 2008, and I would like to walk you through to the most recent one, 2016, with the identification of the heterogeneity of the presentation of phenotypic stroke. You have cerebral infarction, large vessel, small vessel, all right. You have intracerebral hemorrhage with the proportions as indicated within. All right, and we have established that there is a monogenetic cause of ischemic stroke. Meaning to say one gene that has been mutated, and the gene for NACH, for CADASIL, gene for HTRI1 for CARASIL, CADASIL cerebral autosomal dominant arteriopathy with subacute infarct and leukoencephalopathies. All right, and there are also, and we have identified this up until the present, including the genes that will increase the risk for intracerebral hemorrhage, for CAA and call 4A1 syndrome at the bottom. All right. This is an example of a monogenetic cause, the CADASIL syndrome, presenting as a large vessel, a small vessel infarcts. You have genome-wide loci for complex forms of ischemic strokes, likewise. No? All right, meaning to say you have identified some the genetic loci for risk for increased risk for strokes in terms of ischemic strokes, all right, and intracerebral hemorrhage as well. This has been this hung up. Okay. And okay, you have the genes HDAC9 in chromosome number 7 and PITX2, which will be responsible for specific forms of strokes in there. All right, they have identified this appropriately. This has been validated by a recent data as well, and will not be going through this. Now, it can also, this genetic locus for risk of strokes can likewise provide us with the possibility of providing what will be the functional outcome. The red ones are the gene loci that will be increasing the risk and risk of a worse outcome, and those that have been highlighted with green ones, if and whenever it will be expressed naturally without mutations, will be the one that will be protective against a worse outcome. So you have a better outcome with these green genes. So we have seen that, decreased cerebral blood supply. You have genetic abnormalities, mutations that we can look at, that they have been providing us with the data. You have specific gene loci, all right, that increases the risk for apoptosis and probably problems with neural repair. The same thing with large vessel disease, all right. You have your monogenic and your polygenic causes to cause small vessel disease that will lead to the various forms of strokes in here. So in other words, you have a lot of things that we can utilize, but this is a lot of noise. We'll have to look at the signals, all right? Because we can use this for precision medicine as well. All right, you have on the left side the common variants, meaning to say the polygenetic, on the right side monogenic, and then you have the stroke susceptibility because of the known risk factors, which likewise can be genetically be traced into abnormalities and mutations in specific gene loci. And it can, if we gather them all together with the neuroimaging, perhaps we can personalize therapeutic strategies, and the application is very, very promising for pharmacogenomics, meaning to say we can probably predict who are the people who will be, likewise, if we can identify the exact gene sequence that, if mutated, will provide better response among patients being given aspirin versus patients who will not be responding to aspirin, if we can only identify all of these things. So All right, we have been recognized, and as a matter of fact, we have an invitation for the Festival for Genomics. All right, I have 2 minutes. And our priorities in the Philippines still will be cardiovascular diseases. All right, the first ever Filipino genome mapping was done in 2014, and they have associated the ethno-linguistics, meaning to say they looked at the various primitive Filipino genes, ITAs, ANGOTs, etc., and what they found out, okay, that we can truly be a part and parcel of, and we have some genetic connections with those in the Native Africans who migrated southwards to include the Philippines. All right, and our genetic makeup doesn't seem to be different from those of the Australians and the Africans. That's just about what has been and what I can gather in terms of published reports regarding genomics in the Philippines. There is an ongoing one, the Filipino Genome Research Project, History, Evolution, and Origins, and this probably will add up to our utilization of this genomic science and whatever it will contribute to our knowledge and classification, accuracy in diagnosis of strokes, and precision medicine is something that we'll have to look into. All right, this likewise has been there for the past 6 years, but we're still awaiting the results. The same report that was flashed to you in 2008, and this is the same thing that they would like to establish, the relationship of myocardial infarction with strokes among Filipinos. Maraming salamat po sa inyong pakikinig.
Thank you, Dr. Alejandro Baroque II. And now, let us welcome our second speaker, Dr. Alejandro Bimbo Diaz.
Good morning, everyone. Before I start my short talk, 20 minutes lang, I'd like to ask, how many of you here have good immune system, you think? Subjective, taas ng kamay. How many here have good stress level, managing stress? Ba't ang konti? Well, next question. How many of you here have medications for hypertension, maintenance? Marami-rami. How many of you here have no hypertension? Wow, dami. Great, ha? Okay. Kasi yun ang topic ko ngayon eh. So, I told Conrad kasi, nung he asked me, he gave me a topic actually. Sabi ko, Conrad, sayang yung lecture ko last February 2025, which I gave in the PSH, as very few neurologists present in that organization. So I thought of sharing the role of the autonomic nervous system. Tayo, neurology in cardiovascular disease and hypertension. And also the psychiatric aspects. That's why dinagdagan ko psychosocial stress. And as you know, we're always bombarded with so many stress, and it will depend on how we handle stress, the balancing between good stress and bad stress. Diba? Good stress, if you go to the gym, you walk, wala yun. It's very helpful. But otherwise, negative emotion stress also harnesses immune system that are bad to we'll talk about the vascular system. So that's my introductory. So we will explore some of the groundbreaking publications in neural and psychosocial regulation in immunity and inflammation, how it really affects. Because when I learned neurology during my residency, parang di ko yata ito nakita. So actually, after this, anyone who would like to, I can share my PDF lecture because medyo mahaba ang lecture ko, pero I'm only limited to 20 minutes. So how can I deliver this lecture? But anyway, this slide just shows you that there are areas in our brain that are open or leakage prone to blood-brain barrier, and those that are around our ventricles. We call them the CVO. Hindi cardiovascular o yung pharmacy, circumventricular organs that connects to our peripheral system, that connects to our bone marrow, that connects to our spleen. So yun ang connection. Sabi ko, di ko yata ito alam before, no? And the autonomic system, we have the parasympathetic, relax, di ba? Rest. And then the sympathetic nervous system, there's always a homeostasis. What happens is, environmentally and endogenously, this can actually tip the weight towards more sympathetic overdrive. And when that sympathetic overdrive, it passes to the nerves. And we have nerves that goes to our bone marrow, to the monocytes. Akala ko wala mga nerves yun. Meron pala. Indirectly and in both indirectly. And because of this leads to a dysregulation of our immune system. So I thought that siguro kaya pala yung mga rheumatologists, they saw a lot of this when exacerbation of rheumatological condition when the patient is under stress. So from the brain, not only from the circumventricular organs, also it creates connection via the HPA axis. Pag yung mga cardio, mga nephro, ang alam lang nila RAS, renin-angiotensin-aldosterone system. Kasi wala tayo dun, it's equation eh. We should be present. That's why we neurologists should be more in attendance with heart and brain, or brain and heart meetings. Kasi there's really a connection. And of course, because late lang, the seminal publications, medyo in the year 2020s or late 2000 pa lang. Okay. So you can see that even in the B cells, in the thymus gland, we know that the thymus, myasthenia gravis, the stress can actually make our T cells, our thymus gland involute further with this. Okay. So next slide is, does the neuroimmune axis have a role in the development of hypertension and atherosclerosis? Of course, the answer is yes. Okay, and as you can see there, because of this high sympathetic drive that goes to the spleen activation, and this results to an egress of immune cells. All the immune cells, these target organs, even the renal disease, even in those, Dr. Navarro knows this better, and the ostia. That ostia opening in from middle cerebral artery, anterior cerebral artery, before it penetrates, those penetrating, we have ostia. There is a physiologic neurointimal hyperplasia. Unfortunately, when there is stress or blood pressure variability, nagkakaroon siya, there is a tsunami effect that actually opens up the tight junctions, which can lead to vascular damage, and sometimes we see these white matter changes, acute lacunar infarcts, and so on and so forth, which can lead to later on dementia. So these are not acute things that happen. This is a slow thing that happens, especially when we are subjected to more chronic unmanaged stress. Okay. So they saw this in experiments in animals. So they look at this. Ano ba nakalagay dito? The cat, ginugulo na sinishake niya yung cage of rats. And they saw that this actually led to bone marrow activation, immune progenitor proliferation and release, splenic activation, immune cell homing and proliferation, which actually leads to arterial wall inflammation. So atherosclerosis is not just LDL. There's a significant amount of immune cells there, monocytes, macrophages. And when one is stressed, it's not only the LDL in the hip and the liver, it's not only the salt in the liver, but stress is a very important factor. And if it is just short-lived stress, okay lang yun. However, when it is a sustained stress, that's the problem. Okay? And they saw this. Okay. Even in conditions, medical conditions such as sepsis, this can give rise to cholinergic inflammatory pathway overcharge, neuroimmune mechanism, which leads to cholinergic stimulation, okay? And also cognitive function, you can see all of those, there is a connection between even the gut and the brain, and even in the lung and the brain, lung-brain axis, wala dyan, no? And all of this, the common denominator is it actually from the neuro to the immune cells, there is a significant connection. It's a bidirectional. We thought it was a unidirectional lang doon. There is a feedback communication between the two systems. Also, in chronic psychological stress, they saw this in animal models, even in human, that stress activates the bone marrow sympathetic nervous system, splenic. So therefore, it's important that, okay, we saw those patients. We wonder why some of our patients who have metastatic prostate cancer, I know some doctors who, in the past, sabi ko, Doctor, galing mo naman, stage 4 ka na. I manage my stress. So therefore, I think stress management is an underestimated way of managing medical condition, not only cardiovascular diseases. So hypertensions develop via a self-reinforcing cycle. The first three are physiologic. Pwede pang ibalik. Okay? But pagka nagkaroon ng vascular remodeling, fix, increase in system, vascular resistance, arterial stiffness, point of no return, because there is now a remodeling, anatomical change in the blood vessels. So this is just I made this caricature just, that stress really is heavy. Okay. Each one, smoking, dyslipidemia, hypertension, diabetes are important risk factors, but stress is probably not well discussed. Why? We don't have a very good scales of scoring. We have a stroke scoring system, depressive scoring system, but stress, what is an important, meron ba tayo na validated stress, how much is really stress? Meron yata, no? But I haven't included in this lecture. So again, I would like to emphasize that the HPA axis, hypothalamic pituitary adrenal axis, has a direct connection to the renin-angiotensin aldosterone system, and it also has a direct effect in the adrenal cortex, increasing the cortisol, driving up the sympathetic and the inflammatory conditions as a consequence of that. Fortunately, we have innate and adaptive. So the adaptive response, again, it depends on, in physiology, okay, you always have pro-inflammatory, anti-inflammatory. So therefore, just like fever, inflammation is good sometimes in our condition if it is not sustained. Okay, when we do to the gym, exercise, all of the short bursts of elevated blood pressure is good, just like hormesis. When you have small stress, few stress that will not kill you is good for you, it makes you stronger. This is the same, the adaptive response, innate immunity, okay, I mentioned earlier. So there is a delicate balance between pro-inflammatory and anti-inflammatory responses, and T-regulatory cells are vital for vascular homeostasis and suppress excessive inflammation and oxidative stress. And the resident macrophages and the vessel wall modulate vascular reactivity and nitric oxide production. That's the reason why in the later slides that I will show you, it's not only the usual drugs that we're giving, we're now looking into neuromodulatory, anti-inflammatory, monoclonal antibodies that particularly targets that new findings of inflammatory condition that affects our blood vessels, the endothelium, and so on and so forth. Okay, I think we can go this. Okay. Oh, we talked about this already. So, okay, this is the same that they saw. Stress can increase adiposity, insulin resistance, increase sympathetic nervous system activation, and we mentioned about this. And therefore, we saw that some people, despite their diet, their exercise, cannot lose their weight because of stress. And one of the reasons is because it increases insulin resistance and, of course, visceral adiposity. Okay. We mentioned about this, that there is a nervous system connection to the bone marrow production of antibodies, monocytopoiesis, goes to the plaques, and then the inflammation, actually, it's not just the atherosclerosis, but when there is an inflammation, and that inflammation can be affected by stress level, which can lead to plaque rupture. That's the reason why sometimes we do see in our history taking of cardiovascular event, stroke, heart attacks, it is preceded by an acute, severe stress factor or event. So they saw this also, no? In this study, I think this is in UK, income, okay, how it affects higher income, lower amygdala or stress center in the brain, noise. Okay, if you live in a very noisy area, it increases the amygdala activity, and this was associated with higher major cardiovascular event. Income also. The lower the income, unfortunately, poverty can drive MACE also. Of course, MACE, we mentioned about that. Okay. Okay, it's basically the same. Stress, neural activity, higher amygdala volume. So I'll go now to evolving immunotherapeutics, both pharmacologics and non-pharmacologic. So you know the canakinumab, right? In 2017, I think, Paul Ridker made a huge excitement in the cardiology world because for the first time, he actually proved what was shown in animal studies, that inflammation beyond lipid level alone or LDL alone has a very important risk factor in cardiovascular event, including stroke. And he used an agent called canakinumab, which inhibits the interleukin-1 beta neutralization, and TNF-alpha, and IL-6, I think. And they demonstrated targeting the inflammation reduces cardiovascular event significantly by 15%. That's the reason why, because of that, the cardiologists started to check the HSCRP, which in the past, decade ago, they did not include it in the guidelines. Now, of course, we also have our own, okay, but in cardiology world, they talk about colchicine, a very cheap anti-inflammatory that addresses the inflammasome. Ganun din tayo, no? The CONVINCE trial, not very convincing yet, but the COLCO trial showed a reduction in both cardiac event as well as in stroke events. So I think the CONVINCE trial is also addressing that, and there are many other more studies. Just take a look at that. Okay, many. These are new things that are not yet prime time for them, but I just wanted to show that there are etanercept, even the COVID monoclonal antibody, ano ba yun? Tocilizumab, is being experimented kaya may side effects. Okay? So I think in the future, we will see further in the PubMed maybe, the best way to look at it, or the clinicaltrials.gov. And of course, these are the emerging therapeutics, bioelectronic ultrasound, fine-tuning, vagosympathetic activation of the spleen, bioelectric stimulation of the celiac efferent nerve. However, how can I move this? I saw this in one of the conferences. Okay, so this is something, although short-lived, if we do this, or if we tell our patients regularly, you do this, the proper way of breathing. Many patients don't know how to breathe properly. So inhale, breathe in, we can probably do that. 4 seconds, hold for another 4 seconds, and breathe out through the mouth, open mouth, 4 seconds. And then if you check your blood pressure, you can actually see lowering it. By the way, I did not include in my lecture is this ABPM. the ambulatory blood pressure measurement, which I'm wearing one in my watch, actually has been shown that your stress level during the day, you can actually see it. And if you have, you can carry it out when you sleep, because our blood pressure should dip when we're asleep. We are dippers. However, if you have problem with stress, of course, snoring, sleep apnea can affect that. It can actually tweak your health and vascular health towards the disease process. So I think I'll stop on that. Thank you very much for your attention. Bye-bye.
Thank you, Dr. Alejandro Bimbo Diaz. And now let us welcome our third speaker, Dr. Loreto Talabucon Jr.
Good morning, everyone. Mayang buntag from Cagayan de Oro. First of all, thank you for the organizing committee for the invitation to be part of this historic event and to be with these esteemed colleagues in this particular session. So earlier they were talking about primary prevention, and now I'll be talking about some approaches on secondary prevention. So I'll be talking about antithrombotic therapy. And when we talk about antithrombotic therapy, the word that comes into my mind is actually about prevention. And then this quote by Benjamin Franklin comes into mind: an ounce of prevention is worth a pound in cure. So even though Benjamin Franklin was talking about fire prevention at that particular time in the 1700s, but I think this adage still holds true among stroke even in these times, 21st century. And incidentally, Fire Prevention Month was last month. So why do we talk about secondary stroke prevention? So we know from our clinical practice that about 1 in 4 ischemic strokes is actually a recurrent event. And I think it's very important to treat or to prevent the next stroke aside treating the first one. So we know from meta-analysis studies that shows that the recurrence rate for secondary stroke events is actually high, about 60% in 1 year among patients who had TIA or minor strokes. And the risk actually continues to accumulate. So it reaches even up to 13 to 20% within 15 to 20 years' time. And we all know that recurrent strokes carry significant sequelae. So not only in terms of increasing disability, but they also have some cognitive sequelae and also has some indirect costs, like, for example, increase in caregiver burden and other societal costs like loss of jobs, loss of some economic opportunities. So right now, the mainstays of our secondary stroke prevention, so these are the cornerstone of our approaches. So we have lifestyle modification. So this is the Lifestyle 8. This is adapted from the American Heart Association. So it's basically knowing your numbers, controlling the blood pressure, keeping your blood sugar down, keeping your weight down, having regular exercise, diet, and so on. And as well as controlling your underlying vascular risk, hypertension, diabetes, lipid management, and so on. And of course, thrombotic therapy. So right now, our current antithrombotic recommendations are based by etiology. So we are guided by etiology in terms of our specific agents to use. So for example, for cardioembolic stroke, we use anticoagulation. So the darlings there is actually your DOACs. And of course, warfarin is still there. And for highly select patients, we can actually consider left atrial appendage closure. And for intracranial atherosclerotic disease, based on the SAMPRIS trial, so we give dual antiplatelet therapy for about 3 months and then a single antiplatelet for long-term management. For non-cardioembolic stroke, minor strokes, or TIA, so we use dual antiplatelet therapy for about 21 to 30 days, followed by single antiplatelet therapy. So this is based from the CHANCE and POINT trials. And for ESUS, or non-cardioembolic non-minor stroke, we know that DOACs are not really efficacious there, though there was no increased bleeding risk in those particular studies that look into the ESOS trial, like Atticus, Respect, Arcadia, and Navigate, except for Navigate. So the treatment recommendations for ESOS is still actually single antiplatelet use. So right now, there are certain limitations with these current agents. Bleeding risk is still actually a major concern. So this actually leads to undertreatment. There's some off-label decrease in the dosage, which could lead to efficacy concerns. And of course, we know that long-term dual antiplatelet is not recommended. I think the probable exception would be the cilostazol-based combination as shown in the CSPS.com study, but that drug is not widely used outside of Asia. And there's still a need for BKs, for warfarin, which we know it carries its own inherent limitations besides its narrow therapeutic range. So this is actually a picture of Indiana Jones in the Last Crusade showing the Holy Grail. So the last night Templar said, "Choose wisely. The true Grail will bring you life. The false Grail will take it from you, or will bring you death." So I think the Holy Grail for antithrombotic is an agent that will be efficacious with no or less bleeding. So how do we choose about this? So I think this brings us to the factor 10 inhibitors. Is this the Holy Grail of antithrombotics? So I just like to show you this timeline of this practice-changing antithrombotics. Warfarin, developed in the 1950s, was the standard for cardioembolic strokes until the era of the DOACs. But of course, DOACs has its certain limitations. It's not effective among valvular AF, not effective among ESOS patients, which are presumed to be non-cardiobolic or non-lacunar strokes. Aspirin became the mainstay for non-cardioembolic strokes together with other antiplatelets like clopidogrel, ticagrelol, the newer ones, prasugrel, and ticagrelol. Okay? We experimented with the use of dual antiplatelet therapy, and right now we know it works in certain populations and only for a limited time because of the bleeding risk, again, based on the chance and point studies and also from data from the SPS3. We do know that combination of antiplatelet and with low dose DOAC might work, for stable chronic vascular disease or for patients with peripheral artery disease like from the COMPASS trial, though we don't exactly know the specific benefit among ischemic stroke patients per se. So are we now in a new era in our antithrombotic treatment? Is this going to be the holy grail of the antithrombotic treatment? So why factor 11? So there are actually some lines of evidence that suggest that factor 11 has less bleeding compared to the other agents while still be efficacious. So first, we have epidemiologic data from patients who have inherited factor 11 deficiency. So these are like hemophilia C patients. They have been associated with lower risk of bleeding, and they have less stroke and less venous embolism. And then animal studies among knockout factor 11 among mice, they noted there was resistance to both venous and arterial thrombosis without an increase in spontaneous or induced bleeding compared to wild-type mice. And of course, there are clinical studies of these factor 11 molecules. So they have been studied among major orthopedic surgeries. So the development of factor 11 inhibitors actually follows more or less the development from DOACs. They started on being used among patients who are going to undergo major orthopedic surgery, specifically total knee replacement. Okay, so these molecules or these factor 11 inhibitors have been shown to have results that showed significant incidence in VTE, DVT, with less bleeding events. Okay. This slide just shows those patients with inherited factor 11 deficiency. So if you look, they have lower events in terms of cardiovascular outcomes. Okay. So they have lesser MI, strokes, and TIA. So how does this work? So of course we know that factor 11 inhibits factor 11, but we would like to look into the pathways that are involved here. So in the hemostatic pathway, which is also called the extrinsic pathway or the tissue factor pathway, so this happens with like a contact injury, so you have a trauma, for example. So normal hemostasis is triggered by high levels of your tissue factor, and it doesn't need any amplification from factor 11. So meaning factor 11 doesn't play much role in the normal hemostasis, okay? While in intrinsic or in the contact pathway, so for example, what would happen in plaque ruptures, intravascular injury, or inflammation from a device placement, like for example in stents, they initiate lower levels of the tissue factor, but then they would need an amplification of your factor 11 to form that thrombus, which is actually going to be your pathologic clot. This is actually in contrast with factor 10. You would prevent the development of the thrombosis, the clot there, but it actually also interferes with your normal hemostatic pathway. So in factor 11, there's actually this uncoupling, which lowers the bleeding risk, but also clinically can also potentially allows co-administration with other antiplatelets. Unlike DOACs, now we know that carries inherent increased risk. Okay. Right now, these are the current factor 11 inhibitors and their respective pharmacokinetic and pharmacodynamic properties. So the first one there is Ionis. It's actually an antisense oligonucleotide. Okay, and then the ozimab, abelacimab are actually monoclonal antibodies. These subtypes are given subcutaneously or intravenously. They have long half-life such that they can be given at least once a week, or sometimes once a month. Our particular interest in these small molecules, the milvexian and the asundexian, they have good bioavailability, so they can be given orally. However, they have short half-life, so they have to be given at least once or twice daily. And I think one of the things that I would like to point out also here is that most of them have minimal or no renal excretion. So this potentially allows their use among patients with chronic kidney disease. So actually that we know that patients with chronic kidney disease carries higher bleeding risk compared to those without it. So we'll now focus on those two molecules, these asundexian and milvexian, because these are the particular factor 11 inhibitors who already have advanced trials. So we'll focus on their stroke prevention trials. So asundexian has been investigated in Pacific Stroke, which is a randomized double-blind parallel group phase 2 trial, and it was the first of its kind when it first started. So they enrolled around 1,800 patients with acute non-cardioembolic stroke, 45 years old and above. So they were either randomized to receive oral asundexian at the doses of 10 to 20 to 50 milligrams on top of standard antiplatelet therapy versus placebo, which is the standard of care or standard antiplatelet use. And in asthmatic, they also used various dosage of oral milvexian from 25, 50 to up to 200 a day. And they have similar primary endpoints, so they look into symptomatic ischemic stroke, and also on MRI. The main difference there is Pacific look at it at a much longer time window at 26 weeks, so that's about 6 months compared to 3 months for milvexian. So for the Pacific Stroke study, it shows that there was no really significant difference among the different outcomes in terms of the different dosages. And however, in their post-hoc analysis, it actually demonstrates there that there was actually a reduction in the composite outcome of recurrent ischemic stroke compared to asundexian, and among patients with TIA. And if we look into their safety outcome, there was no increased bleeding risk across the different dosages of asundexian compared to placebo. And with the asthmatic SSP study, there was no significant difference in their composite primary endpoints. And there was actually a approximate 30% relative risk reduction for symptomatic ischemic stroke for all dosing regimens, except for those in the lower dosages of 25 and to the highest dose of 25 milligrams. And with regards to its safety, the incidence of major bleeding was also low, but there was a numerical increase from the dose of 50 milligrams and above, but it is not statistically significant. So because of the success of these phase 2 trials, they moved into phase 3. So Limbrexia stroke is actually a randomized double-blind trial. The study is still ongoing. Okay? So they used the 25 milligrams twice daily dose, and they enrolled patients with acute ischemic stroke or high-risk TIA, and the primary outcome is time to first occurrence of ischemic stroke. Now let's go back to asundexian. So this study is actually already completed, but the full paper has not yet been published, but the key findings have been presented in the ISC last February. Initial top-line results were presented last October during the WSC conference. So the inclusion there are patients with non-cardioembolic stroke or high-risk TIA with history of atherosclerosis, and they excluded patients with AF and with history of bleeding and so on. So standard exclusion criteria for stroke trials. So they looked into the efficacy is time to first occurrence of ischemic stroke. And of course, the safety outcome is bleeding events. So as you can see from this graph, there's a hazard ratio of 0.74, translating to a 26% relative risk reduction compared to the use of placebo. And this benefit actually started early, like about less than 90 days, okay? And the results were actually also consistent among the different subtypes. So regardless of their age, sex, stroke, subtypes, their knee score, or whether they use single or antiplatelet use. And of course, importantly, there was no increase in the major bleeding or even in the minor bleeding events. So the bleeding risk for hemorrhagic stroke, symptomatic ICH, and fatal bleeding were similar between the treatment groups. So the conclusion in that study showed that there was a large treatment effect of 26% reduction in reducing time to first recurrence of stroke. And then this difference started early and persisted throughout the study, and there was a consistent effect among the different subgroups. And there was no increase in bleeding rates, including both major or minor bleedings. Okay. So what are the clinical implications for this? So this study actually shows proof of benefit with the decoupling of hemostasis with factor 11 inhibition, and the combination of factor 11 plus standard of care, which is antiplatelet, actually addresses an unmet need for secondary stroke preventions for high-risk ischemic stroke patients, and actually could be an alternative or would support a shift in the secondary prevention from a dual antiplatelet combination to a combination of antiplatelet therapy plus factor 11 inhibitors, and that would actually also probably address the increased recurrence on patients who are already on just single antiplatelet use. So basically, this reduction of thrombotic events and ischemic stroke without the harm from bleeding represents a step forward. So what's ahead? So actually, I think we're looking at a new or the next generation of antithrombotic agents that may usher a new era for secondary stroke prevention. Of course, we are still awaiting results from other trials. Asundexian has received a fast-track designation from US FDA, but not yet approved for clinical use. We do hope for better implementation once this has been more widely available. So we'd expect changes or updates in the current guidelines. We also expect broader real-world adaptation, but of course, cost and accessibility is still a specific concern. So I think it's going to follow a similar pattern how the WACS came to us in the Philippine setting. So I think by the 10th Biennial Congress of PAVIN will have generic forms of these factor 11 inhibitors. So hopefully that will become more accessible to Filipinos. Okay. So the present data shows potential for meaningful benefits for patients for stroke. And there's still going to, I think its role among AF would still has to be clarified. We know that it's still, it's negative, no? For like Pacific AF and Oceanic AF were negative for primary prevention among patients with ischemic stroke. Okay. And on a lighter note, shout out to Jen, some of you are looking forward to the BTS concert, starting April 11 in Goyang. Okay, so that's my last slide. Thank you for listening. And actually, if my lecture is a synthesis of numerous videos from the World Stroke Academy, so you can actually look into their YouTube channel. So for more information. And of course, that data on asodection was presented during the plenary session by Professor Sharma at the ISC 2020. Thank you.
Thank you very much to our distinguished speakers for their insightful and thought-provoking lectures. Your expertise has truly enriched our understanding of stroke prevention and management. We will now open the floor for questions. Kindly note that the QR code has been available throughout the lectures, and we will be addressing the questions submitted by our attendees. You may also opt to ask your questions live by approaching the microphone placed around the ballroom. So let us now begin our open forum. Any questions? Any live questions? Okay, sige, I will start the question. This is a question for Dr. Baroque. So, Doc, how different is the genetic architecture of a stroke risk among Filipinos compared with Western or Asian cohort, and how should this influence our prevention strategies? Is there a unique gene for Filipinos that is why we have an increased risk of stroke compared to our counterparts?
Okay, I just had some time limitations. I was about to explain the only Filipino cohorts that had been presented in that particular published report in 2014 is a mitochondrian DNA analysis, all right? And they looked at the varied linguistic differences among the Filipinos from north to south, looking at the most ethnic population. And they compared it with the genome studies, and they found out that we don't have any difference. The Negritos, the Atas, the Africans, Australians, the genetic makeup doesn't seem to really differentiate one from the other. So it's a Homo sapiens kind of DNA that more or less is being emphasized. All right. Now, with regards to its application to stroke, that is now what we are looking forward into. What we had, as I presented with the 2 or 3 most recent analysis, meta-analysis review, they identified gene loci, meaning to say sequence of the nucleotides in a particular chromosome, in particular chromosome number 9, that had been identified to have a high risk for the expression of myocardial infarction. And the same loci, at least most of them, had been associated likewise with the expression of hypertension, diabetes, and atherosclerosis. The same risk factors for strokes. So they did the analysis looking at 17,000 strokes in that particular paper, And they found out an association, meaning to say it's the same genes that will predict the expression of cerebrovascular events. So with that, that was 2008, they labored into and identified specific gene loci that will have a high risk for an expression of the varied phenotypic expression of strokes. Large vessel, you have a different gene loci activity. But we have not yet compared the Filipino cohorts with this presentation. So we're looking forward with the final cardiovascular genomic project by the Philippine Genome Center, let's say in UP Diliman, and they are laboring into that. And hopefully we'll be able to gather some more of these biomarkers, as we can probably, if you may, probably signatures, not just one, probably a complement of each other, and then looking at atherosclerosis and all other risk factors, you have a checklist, and voila, you have a precision type of classification of strokes, or prediction of the possibility of a patient not having strokes to be having strokes in the future. And precision medicine, as presented a while back, sino sa mga pasyenteng ito ang factor 11 ay magre-respond, sino hindi. So that is looking forward, and I'm also looking forward to that age and time. And probably the president of PAVIN, the brilliance of mind, he is the future of AI in neurology, I guess. He's a walking encyclopedia. Perhaps he will answer that question later on. Alan, so I'm challenging you on that. All right, so I hope I have answered
Thank you.
appropriately.
Thank you, Dr. Baroque. Yes, Dr. Cañete.
There is an ongoing study, or we will start a study, an observational study on stroke and genetics, stroke and radiomics, and stroke and genomics. Dr. Navarro wanted me to let you know that it's about to start. So I think apart from the very good lectures, and we know more about genomics, we also are encouraged to do more in terms of research to get our own data. Kaya nga, the very nice, you can say, theme is reimagine, that the Filipino researcher also brings more data to the world. And as Richie was talking about Librexia, and you have beside you the #1 researcher for Librexia. And so I just wanted to say that, it's a good time also to increase our research capability and also add to the data for the world. Thank you.
Thank you for that comment. Let me just, I just wish you all the luck, Dr. Cañete, because the Human Genome Project only involved 20 individuals, and the cost at that time was $783 million. So that's something, again, a challenge to everyone. But I'm sure 2 weeks from now, if the world is still existing, because that's the to annihilate human civilization, right? Okay. So I'm hoping that we can really translate this into our Filipino population. Sort of checklist. Meron kang ganitong gene, number 1, 2, 3, 4. Okay, magkakaroon ka ng large artery disease. Gene 1, 2, 3, 4. Ito ang classification mo. Gene 1, 2, 3, 4. Ito ang magre-respond sa gamot na ganito. All right? So that's just my hope in the future. Thank you. Thank you, Dr. Cañete, for your...
Yes, Dr. Bonnie.
Just to follow up with what Dr. Cañete said po, we're really actually very proud of this project. We're working on it together. Dr. Cañete, Dr. Navarro, me, and Dr. Joyce Porto, the neurogeneticist. No? So we already have funding for it acquired from the OST, and it's about to start in 2020, next year, 2027. So it's specifically for ICAS, but of course, and we're going to collect a lot of data from at least 500 people. So we're really excited about it because it will be the first nationwide genomic study, particularly in stroke in the Philippines. And we hope to update you later on with the results, findings of our study.
Okay,
I
thank
wish you all
very
the
much.
luck, Bonnie.
Thank you very much. So research really is the way to go. So this is a question for Dr. Bimbo Diaz. Doc, what is the strongest current evidence linking psychosocial stress directly to increased stroke risks independent of the traditional vascular risk factors?
Yeah, I think the literatures, if you look at the PubMed, there are many, but they're not very strong yet. But moving forward, I think we should really look into that, and maybe I know the PPA should be the proper organization that should look into this psychosocial stress, because we know that not only that, but mental health is a big issue. It's not only the physical health. I'd like to add to we're looking into the milvexian actually. It's going to be finished. Our last randomization will be on April 10, and Philippines is one of the active participating countries. And I hope it will see what we saw in the asundexian or the oceanic, that it was positive in non-cardioembolic stroke, but asundexian was negative in acute coronary syndrome, and we're still waiting for the asundexian AF. Same thing with milvexian. We're looking into hopefully that it will be one armamentarium in addition to anti-factor 10A. But of course, the promise of this agent is less bleeding, more targeted compared with the vitamin K antagonist, and of course, the anti-factor 10A.
Okay, thank you very much, Dr. Diaz. Any other live questions here? So I'll proceed. This is a question for Dr. Talabucon. How soon do you foresee factor 11 inhibitor being incorporated into the routine stroke prevention guidelines and clinical practice?
Well, I think, like for example, for asundexian, it already received fast track designation from the FDA. So maybe by later part of this year or next year, we could probably see that. And if the results of the Librexia would be positive, I think that would be a stronger impetus for the approval of this particular kind of drugs. But of course, in terms of adoption in our setting, we know that cost is really going to be a big factor here. So yeah, I'm not too sure, but they discussed some of the cost factors before, and they really want a really strong endpoint outcomes that would really pivot the shift from the traditional cheaper antiplatelets versus the add-on of this.
I think I agree. Since these are new agents, we expect them to be quite expensive. Wala pang mga generic. But what I would like to point out is that the cardiology are now very strong. A lot of them are strong and using low-dose colchicine. And if you look at the Colcott and Loreto study, of course, the CONVINCE trial was affected by the COVID, but if you look at the trajectory, it is actually beneficial. It's low dose at 0.5 milligram. How much is colchicine nowadays? And of course, except for a temporary side effect of GI, it's a very good agent that can inhibit or suppress the NLRP3, the inflammasome activation pathway. So actually, in practice, I have already incorporated that. The patient does not have to be have gout or hyperuricemia. If I see the patient's CRP or HSCRP is elevated, I would talk to that patient. Of course, pang gout ito, doktor. I will inform him of the current studies that are circulating around. Thank you.
So I'll add on. Being a resource-poor country or resource-poor setting, So I think our resources should be, really should be on primary prevention. So it has to be like controlling these other vascular risk factors. So we really have to strengthen in like controlling hypertension. That's one way to really bring the incidence or the mortalities or morbidities from stroke, rather than really focusing on treatment. So, the stroke already happened. So it's like I keep on telling, when I lecture on patients on lay fora, I would tell them, if you have hypertension, you have diabetes, better control it now. I don't want you to become my patient, because once you have a stroke, you're going to have a lot more drugs. So I think our thrust should really be on primary prevention.
So thank you. May I take that opportunity to invite all the neurologists here under medical to, I'm inviting you to be a hypertension specialist. We have a course this coming July, because we saw that the hypertension control in the Philippines is really dismal. Pre-COVID, it was 30%. Post-COVID, you can check it out in the European Heart Journal. 2021, 22, 23, it went down to 15 to 20%. So a big chunk of hypertensive patients don't know that it's uncontrolled. And just this morning, I attended a plenary lecture by a foreign speaker, and she actually said that most of the time, monotherapy is the exception. We should stop treating our patients with monotherapy. And most of us, neurologists, are for secondary prevention. Okay, if the patient's blood pressure is 140/90, forget monotherapy. It has to be 2 drugs, low dose. It's not you increase the dose to higher dose before you add. No, it has to be, because there are more side effects, and dual combination or increasing the dose, more side effects with very minimal, just 2 to 3 millimeters of mercury. So the speaker kanina talk about triple, 3 single pill combination, in the studies, she really showed that it actually lowers down. So I think most of us don't realize it, that when we see patients with stroke, a lot of them have uncontrolled hypertension, resistant hypertension, to add more to non-adherence. That's a big problem that we're replacing now. Another project that we're starting now, maybe it's the first of its kind in Asia, a dedicated organized hypertension clinics spread in the barangay as well as the primary, secondary, and multi-specialty referral system for those that are uncontrolled hypertension.
Okay. So if there are no more questions, I'll now proceed to the synthesis of this morning's session. Dr. Baroque's lecture highlighted the growing role of genomic signatures and molecular biomarkers in improving stroke prediction risk. The discussion underscored the importance of developing an ethnicity-tailored risk factor rather than relying solely on Western dataset. Dr. Bimbo Diaz's lecture emphasized how chronic psychosocial stress contributes to cardiovascular and cerebrovascular disease through activation of the neuroimmune axis. The discussion highlighted the importance of recognizing stress as a modifiable biological risk contributors rather than a purely psychosocial issue. And our last speaker, Dr. Talabucon, highlighted the evolving paradigm of an antithrombotic therapy from a traditional broad-spectrum anticoagulants towards a more targeted approaches, such as the factor 11 inhibitor designed to decrease thrombosis while minimizing bleeding risk. So emerging clinical trials suggest that these agents may offer safer alternatives for stroke prevention. So thank you to our speakers for graciously answering the questions, and to our audience for your active participation. This exchange of ideas is what makes our convention meaningful and impactful. As we conclude this plenary session, let us carry forward the insights we gained today. On behalf of the organizing committee, I extend my deepest gratitude to our speakers and to all of you for being part of this important dialogue. We wish you a pleasant day ahead as you continue to engage in the rest of the convention. Maraming salamat po.
Thank you to our speakers, Dr. Alejandro Baroque II, Dr. Alejandro Bimbo Diaz, and Dr. Loreto Talabucon Jr., and to our moderator, Dr. Muqtader Kalbi.